Good morning, everyone. It's nice to see all of you. Thank you to Sharon and Jeannie, who are the founders of this really important support group. We appreciate every effort that you have towards the community of caregivers. And to all of you who are here this morning for the first time, I'm sure it won't be your last time. I love to see all of you and hear about the progress that you're making. Today, this is a very special weekend. So to the men in the room, we honor you. Mr. Dixon, Mr. Thompson, we honor you and the men's group. Potentially others will join. It's also exciting to see Monica Moore, who is the Community Health Program Manager of the Mary S. Easton Center for UCLA Research. I appreciate Monica and all the work that we've done together throughout the years. Dr. Sarah Kremen, who's amazing, an associate professor of neurology at Cedars-Sinai Medical Center and the director of the neurobehavioral program at Cedars-Sinai Medical Center. My mother worked for Cedars-Sinai Medical Center for many, many years. And so I'm always aware to never say Cedars. So I appreciate that. So it's the long name, but it's the official name. So Tonya Jones, who we've worked with before, a previous self-care event where she's a teaching artist, a leadership and a wellness consultant. She has so much to offer. So welcome. Self-care, why it's important. It's important because one of our local, I think a community member and part of our dementia care network, her name is Eleanor Brown, and she made a quote some time ago, and her quote is, you can Google it. It's amazing. And she said, rest and self-care are so important that when you take time to replenish your spirit, it allows you to serve others from the overflow. And finally, the last critical part of that statement says, you cannot serve from an empty vessel. And that's per Eleanor Brown, an amazing woman that's still with us and still shares information. So that's why we're here today, so that you to make sure that you do not pour, because you actually can't, from an empty vessel. So you are going to be built up this weekend so you can continue your journey. And I see Mr. Green has entered the room. Happy Father's Day. We honor you. Thank you for joining us. And so I'm going to turn it over to Monica Moore.
Hi, everybody. Good morning. Thank you very much, Petra. And again, want to give a very special thank you to Sharon and to Jeannie and to Kimberly for allowing us to come into this space and to be able to work with this wonderful group of the ACTS support group members. It is a great pleasure, and I am very appreciative of your time and what all of you allowing us to come in here today. So I'm going to actually talk a little bit about just the world of caregiving itself. I actually have some slides here to mainly just to keep me on track. So I'm going to just pop open here to share my screen. So we can do this and then go here. And so just talking about the world of caregiving and caring for the caregiver, you know, this is a quote that has been used around a lot. From Rosalind Carter. And there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. You know, I think people they think that, oh, I'm never going to have to do this, right? They think, oh, no, like, this isn't going to be something that I can ever relate to. And you see how we all will fall into this category in one way, shape, or form throughout our lives. And she also says, caregiving is hard, even on the good days, when it brings joy and fulfillment. It requires dedication, determination, and time. And again, finding the support from groups like this is really what gets people through it. And when we think about the world of who are caregivers, so, you know, this group, everyone here who is an ACTS member, obviously you are all, I would assume you're all self-identify yourself as caregivers, but lots of people don't. And we always want to try to just sort of level set it so people understand, again, this world of caregiving. And it's not just a paid caregiver. Sometimes People say, oh, no, I'm not a caregiver. I'm just, taking care of my mom. I'm not a caregiver. I'm just taking care of my husband. It's what any wife would do. I made vows and I committed to these vows. But we realized that the world of caregiving is beyond that. It's happening next door to us every day. It's happening in our homes. We see, 66% of caregivers are women. 25% are caregivers of their parents as well as young children. Recently through the Easton Center, we opened up a support group sort of specifically for this population, what we call the sandwich generation, people who are caring for their parents as well as little kids, and the struggles that they go through and how different that is from so many other people. If you're caring for your 80-year-old wife versus your 60-year-old mom and you have a 10-year-old at home. So you see that there's some great differences here. 50% of caregivers work outside the home. And 72% are caring for a parent, a step parent, or some sort of an in-law. And when we look at who the typical caregiver is, the typical African-American caregiver, they're roughly 47-year-old woman caring for a parent. Half of the time, the care receiver lives in the caregiver's home, which is more common than non-Hispanic whites. African Americans caregivers appear to find a stronger sense of purpose in their role of caregiving. And I think that is something that I really, I find, again, just to be one of those culturally different worlds of caregiving. And I believe that, groups like this are so important because we're bringing in that this is a stronger sense of purpose. This isn't just a duty and an obligation. This is honoring, this is respecting, this is caring for our loved ones, not just, well, no one else is taking care of mom, so I have to. And we see that in the African-American population, that it's much more of an honor of respect, of a role of respect, and then in caring for your loved ones. And also that we realize that African-American caregivers less often report being in excellent and good health, which is, again, why we are here today. We realize that health disparities exist, and we want to try to bring some of these tools and these tips to this community to be able to help with being able to better yourself and to be able to better your personal well-being as opposed to just the person that you're caring for. While caring for a loved one, caregivers often stop taking care of themselves. We see the risks of caregiving are great, poor mental and physical health. I always ask, when was the last time you went to the doctor? For yourself, not for your loved one, but you went. There's an increased death rate for caregivers, misuse of drugs and alcohol, chronic stress and depression, family and marital conflicts, and sometimes early placement in care facilities due to these stresses that caregiving presents. And when we look at the world of caregiver burnout, all of you are doing a phenomenal jobs taking care of your loved ones, but being mindful of what here's on the screen. And I don't like reading everything on the screen. And so that you can see, looking at these things and internally realizing, what are you experiencing? Are your sleep habits changing? Are you a little bit more irritable? What about your feelings of guilt? A loss of compassion. I know sometimes that comes up in our support groups where people say, it's not like, I don't mean to be short with my mom. I just sometimes am. And it's just like, oh, like you've said that already, and it's not being mean. It's just this world of exhaustion and of burnout that does occur. The feeling of helplessness, sort of also thinking like, well, what's your life going to be? Like, what is next for you? Is this what your life is going to be continually, or especially if you're caring for a parent? Like, when do you get another chapter? And having some of this world of resentment, this is all normal. And these are things that, again, groups like this, support systems like this can help you with, but also realizing and highlighting that these could be signs of burnout. And this is where you are going to start suffering. And so you need to try to pull in resources so that you don't isolate, you don't withdraw, you aren't a secondary victim of the illness of your loved one. And when we think about stress, stress is this word, right? We all live in this world of stress. Stress is something that we all just experience, right? but it really actually does have physiological effects on our bodies. You know, when we feel stress in different ways. You know, I'm going to ask people to unmute for a second because I hate just talking at a screen. So how do you feel stress? Like when you feel stress, what's affected for you? And just unmute and talk. I'm not even going to ask, just
Neck and shoulders.
neck and shoulders. Okay.
Shoulders.
I'm more irritable, or like on the previous screen, overreacting. I tend to overreact a lot, but it's probably my nature. I just think it's even more so.
Yeah. You know, why
especially when it comes to her, you know, any little bitty thing. And I don't even think it's always a slight. I just kind of take it that way.
Yeah. Yeah. Anyone else? How do you feel stressed?
Checking out.
Checking out. All right. Yes.
For me, is loss of appetite. I can't eat. Just have no desire.
And I'm the opposite. I eat too much and I'm already trying to figure out what am I gonna buy. But shopping and eating too much.
I would say shortness of breath.
Okay.
For me, eating carbs, just emotional eating and muscular tension in the neck and back pain would be my symptoms that I get. Yeah.
Yeah, and I get a lot of tension in my shoulders.
Start having these little panic attacks.
Oh,
Yeah.
That's me too. I have to go and just like intentionally breathe in and exhale and just slowly regroup. That's my response usually.
Yeah. Anyone realizing any sort of health conditions that are coming through for yourself due to the stress? I know a caregiver in one of my groups, she has eczema, and she says that when she's stressed, her eczema flares up. People say, you know, that they feel that they're losing their hair, like literally their hair, it comes out more when they're in high stress situations.
Well, I actually do have eczema, and now that you mentioned that, it does. When I'm stressing out, I'm itching and scratching. Yeah, that I hadn't really even put that together, but that does happen.
Yeah.
Also, I'd say weight gain. I mean, related to the poor eating habits, but also more inactivity, maybe vegging out on TV, maybe sleeping a little less. And so I think metabolism changes, and so weight gain is, I think, is something I've had. Yeah.
Absolutely.
Yeah,
a lot of times.
Go ahead.
Go ahead, Winston.
Okay, a lot of times I just say, Lord, give me patience. Let me continue to realize it's the disease and not her. And that's what I thrive on, just a prayer, because sometimes going through this journey for 12 years, the patience gets low.
Yeah.
Yep.
Yeah.
I would agree. I have the additional challenge of recovering from cancer treatment, along with caring for my wife. You know, so it's the headaches, the stress, lack of sleep, you know, not being able to eat solid food yet. So my hands are full, you know, and keeping the balls up in the air, and recognizing that there has to be a shift in priorities when I need to, you know, take a break. You know, when the caregiver, you know, for my wife is in, I need to go, you know, lay down, get some rest.
Good. Yeah. Yeah. And we realize that, like, you know, we feel the stress manifesting in ourselves. And that's why I asked, it's because we all manifest stress in different ways. Like, I'm a shoulders person. Like I'm right here. I'm all shoulders. I don't get the headaches. Some people get headaches, you know. So you see how we're all different, and realizing that and identifying that for ourselves is what can also be like our flag. Like, hey, hold on. This is starting to happen. This is, you know, I need to be aware of this. Maybe my eczema is popping up a little bit too much. You know, it's flaring up. I need to find ways to calm down. I'm not sleeping as much. I'm going for a few too many pretzels, you know, going for a little bit too much pasta, you know, realizing these things that are flares up for ourselves so we can take better care of ourselves and throughout all of this. So we look, obviously looking at the screen here, you see this world, this is all the stuff that we just talked about, right? Someone mentioned the shortness of breath. Mentioned, you know, the struggles that people have in terms of the headaches and the tension. It's also going to contribute to long-term problems for heart and blood vessel, you know, increased risk for stroke, hypertension, heart attack. So we need to be mindful of this as well. Also realizing that, you know, the other impacts of stress on our body, you know, the stress hormone, that increased cortisol, that fight or flight that happens to ourselves, GI issues, as people mentioned, and also again, our whole nervous system is affected by stress. So I have just a few little things that I wanted to mention, and then Tonya is going to lead us on more of our bigger self-care piece. But I just had a few little things that I wanted to mention, and then Dr. Kremen's going to come in and speak more to the world of dementia care. So when we all know breathing is important, right? We all know that this is something that we're supposed to do. But typically when we breathe very shallow. Shallow? Yes, we take shallow breaths. And we know that we should take deeper, more relaxing breaths. I actually saw something yesterday that it was a 5-second breathing. 5 seconds. We all have 5 seconds. We may not have a half hour, but we can find these little tiny pieces and these little tiny ways to incorporate this. So when we think about do some controlled breathing, really make sure that it's deep breaths, cleansing breaths, breaths that can actually, where you can feel it through your whole body. Where's my next slide here? Also looking at finding, we say this a lot, I'm sure all of you have heard this 100 times, finding activities that bring you joy. These are things that you need to do so that you find joy. You know, whatever it is, traveling, knitting, gardening, reading, exercise. Sometimes though, I find it's just being in groups like this that could also help. You may not, like, I love on here, it says traveling, and I think that's a great one. But who here has time to travel? Right? You're caring for a loved one with dementia. Are you really going to be able to just take off for a week and, you know, go on a trip and travel? Probably not, right? Maybe in your dreams or maybe on a YouTube video, but finding these ways of seeing what brings you joy and remembering that that is a big piece of your health and your well-being. Practicing gratitude. Again, like Winston said, you know, saying that quick prayer, asking God just for that help and the, you know, the patience, you know, realizing this world of gratitude, that research does show that people who are more grateful have a higher reported level of positive state of alertness, more determination, attentiveness, energy, and reduced stress. So finding the small things to be grateful for, you know, opening up your windows in the morning and hearing the birds and being aware of that and not just, okay, you know, opening the windows, but finding the things to be grateful for. This is my practical tip for all of you. I love this one. I use this in my own life. I think this is good. We're all overwhelmed, right? Who here has stacks in their house? Who has piles? I think we all have piles, right? We all have a pile somewhere in our house that needs to be attended to. We all have things that need to be done, right? Who here has a list of like 100 things that needs to be done, right? Okay. So this is great because this is a 1-minute rule. This is 1 minute. Do something that you can do in 1 minute and set a timer on it. 1 minute where you set the timer and you go through that stack. I guarantee most of it's going to hit the recycling. Right? Because any mail that we get is just junk for the most part. So find these things, be practical with it. Like put away the magazines. Quickly go through them. If that's a magazine from January and it looks like it hasn't been opened yet, guess what? It's not going to get opened. Just throw it away. You know, like, and give yourself 1 minute to complete a task. Unload the dishwasher, put away some cups, organize something. I guarantee in that 1 minute, it will provide you with a sense of relief and take a little bit of the stress off of your shoulders. And then make your goals smart. Make sure they are smart. And we say smart, they are specific, they are measurable, attainable, relevant, and again, time-based. So don't just think, oh man, I would love to clean out my kitchen cabinets. Well, wouldn't we all probably, right? So maybe pick one cabinet and say, I'm going to give this an hour. I'm going to give this 10 minutes and make sure that they are specific as opposed to, I'm going to clean the kitchen today. Well, what part? So finding these things, making it more narrowed and focused. So then it's going to be successful. Because if you say, I want to clean the kitchen today, and you only get to half the counter, you're now going to feel defeated and like, oh, I didn't get to the kitchen. But what did you do? You took care of half the counter. And that in itself could be a really big thing for you. And then again, building your support network. What you have here, family, friends, networks. This is what's going to get you through. This is what's vital. Finding this world of neighbors, you know, all those people that you have who say, if you ever need anything, do you know those people? All those people, if you ever need anything, like Sharon, if you ever need anything, let me know. Call them up on it. You know what, today, Sharon, I really need something. Are you going to the store anytime this weekend? Could you pick up some milk for me? Use them, find a way, call out those favors. Because if somebody needed something, would you do it for them? Of course, right? Yep. Give them the opportunity to do it for you. This is why we have friends. This is why we have community. This is why we have family. It's because we want to help and support each other. So find a way to actually allow them to help and to support you too. And then again, what I just said, and this also, Winston mentioned this, that remember that your loved one's behavior and emotions are caused by an illness. This is not them doing this to spite you. This is greater than that. Ask for help and enjoy the small victories. Hey, today was a good day. Or guess what? This morning was a good morning. I think at the beginning, Greg was saying that it's like, it's not just day by day, it's moment by moment. So you know what? We had a good breakfast this morning. And not just be worried about what's lunch going to bring or what's the afternoon going to bring. Because we could worry and we could be doom and gloom. But let's just look at this world of focusing and being grateful and practicing that world of gratitude. And also breathe. You know, again, breathing, and Tonya's going to help us with this later. She's going to teach us all to breathe later. And just finding these ways to be able to put yourself as a priority, or at least not to put yourself last. You know, I always say, like, I don't necessarily need to be first, but in my house, I don't always want to be last. So how do you find that space for yourself between first and last? Because some days maybe your loved one needs you more, but there are days that you need the care more than they do, your own personal emotional well-being. So this is a little pledge for all of you. I want you to remember this. I'm going to write this in the chat afterwards as well. Caregivers pledge. I will remember that others are there for love and for support. I will remember to grieve for my losses. Again, what you are going through is hard, and it's fine to grieve and to be sad throughout it. But also remember that you're doing the best that you can. So I am done sharing my screen here. I want to turn it over now to Dr. Sarah Kremen. Dr. Kremen, I added an S to your name. That was weird. Okay.
All right, let me just share my screen. Let's share. Can everybody see that?
Yes.
Great. Okay. So thanks very much for having me here today. I'm really happy to be a part of this group this morning and to be able to share in what everybody's thinking about and give you a little bit of information as well as to partake in Tonya's leading of some mindfulness later on. So I'm going to be speaking today about normal aging and dementia. So these are my disclosures. One of the things that I do in my role as a physician not only is to see patients, but is also to carry out research. And so I've been a participant as a leader, a site leader, to do studies looking at how we can find treatments for Alzheimer's disease. So the topics I'll be covering today include what is normal aging and to contrast that with what is dementia. And then to talk a little bit about the risk factors for dementia and what we know specifically about dementia in the African American community. And then to go into specifics about Alzheimer's disease, vascular dementia, and touch a little bit about how we diagnose these dementias. So first, let's talk about memory in normal aging. All of us, I think, have experienced the tip of the tongue where you're trying to think of a word or a person's name and you just cannot get it. And it's like right there and it's on the edge. And then it comes, you can't get it. And then it comes back like an hour later and you're like, oh, there it is. So that's tip of the tongue. And it's very common and it becomes more common as we get older. We also know that with normal aging, people might be a little bit more slow to retrieve information or have difficulty with retrieval or recall. But that's okay. In general, as we age, we still maintain the ability to learn new information, to keep up with day-to-day events, and be able to take care of ourselves, what we need to do in terms of ability to remember people, remember events, remember conversations that we just had, and our own personal history in the short term and long term. So when memory is not a normal part of aging, is memory loss that disrupts our life every day. So it means that we're not able to hold on to new things that somebody just told us, that people might be telling us that we're repeating ourselves, either asking the same question or we're telling the same stories again and again and not realizing it. Oftentimes misplacing things, and we all misplace things. So it happens every once in a while, but this is misplacing things, our keys, our wallet, our phone, our glasses every day. And it's really becoming disruptive to our schedule because it's happening so much. Or forgetting how to do familiar tasks, check our email, be able to do what we need to do at work, be able to use a telephone, or be able to get to familiar places, remember the way to the doctor's office or to our daughter's house, something like that. So what are causes of memory difficulties? Well, there are some that are reversible and some that are irreversible. In the reversible list, I can tell you it can be a lot longer. So this is just some examples, but we might have problems thinking because of medication effects. We might have side effects from medications that make us feel groggy. We may be experiencing depression. We may not be taking in enough calories in our day. We may be dehydrated. We might have problems with thyroid. We might have sleep disorders like a sleep apnea, which causes us to stop breathing a little bit at night. And that causes loss of oxygenation and then poor thinking the next day. But there are also irreversible causes of memory problems. For example, if we have a big stroke or experience head trauma, a real big knock to the head that causes brain damage. And there are also neurodegenerative diseases where the neurons in our brain slowly die, and that's Alzheimer's disease, for example. But there are others. You can have dementia from Parkinson's disease, and there are other things that affect people when they're younger, for example, frontotemporal dementia. So what is dementia? It's, first of all, not a normal part of aging. And I think that's one of the biggest things to understand is that, we always grew up thinking that, when you get older, it's normal. You just have problems with thinking and memory. And, that's just what happens when you get old. But really, we know now from research, that's not a normal part of aging. Dementia is really an umbrella term to explain two things that have happened. One is that there's cognitive decline, and it's accompanied by functional decline. So you're having trouble with some part of thinking, whether it's language or memory or judgment, reasoning, and that's also causing a functional impairment. So that means that you're having trouble telling your medications apart or remembering to take them appropriately, trouble finding your way around, trouble remembering paying the bills, or you're paying them twice and this keeps happening, or maybe trouble preparing meals, trouble with personal care, trouble managing your emails, trouble managing appointments. But the bottom line is it's cognitive decline and functional decline at the same, or, together that make dementia. And as I said before, it's an umbrella term. So when we think of dementia, we think, do you have cognition and functional decline? If yes, then what does it do to? And you can see I have all these things listed here with Alzheimer's in the middle, but you can see there's all these other things like vascular disease, which is the cause of strokes. There's Parkinson's disease, there's traumatic brain injury, there's HIV. So there's a lot of things that can cause dementia. So how common is dementia? Well, in the world, there's 50 million people worldwide who probably have dementia. And on my estimate, trying to get an estimate of all types of dementia in the US, it's about 8.86 million people right now who have dementia. And if you look at this across ethnic and racial groups, you can see that in the African-American population, it's about 36% of those people are of African-American or Black descent. Then you have a 30% who are Latino, and then Caucasian or non-Hispanic white, a quarter, so 25%. And then in the last amount, it's Asian American or Asian API, Pacific Islander. So what is the prevalence of cognitive impairment and dementia from Alzheimer's disease in the African American or Black community? And prevalence means what's going on right now. If you just took a survey, what are the percentages right now? So if you look at this table, what you can see here is that as people get older, you can see that there are a greater number of people who actually have cognitive impairment, whether that be impairment or actual dementia. And you can see above the age of 85, that's over half. So it's 54%. That's a large number of people. And that's more than other groups of people. As you can see, they don't specifically say which other, but that's more than other people of other backgrounds. And if you look specifically at the percent of people over age 65 with Alzheimer's disease by race and ethnicity, what you can see is, again, that the prevalence is greatest in the Black or African-American community. It's 14%, whereas it's 12% in Hispanic Latinx and 10% in non-Hispanic white. So this is a very important topic for the African-American Black population and to really be aware about, because we need to be able to, help and know when to really ask for help and seek guidance for this. Now, if we look at incidence is the number of cases, that appear over a certain time period. So this was a study that's done by a researcher at UCLA who is a public health researcher, and this was taken from cases from the Northern California Kaiser Permanente health system, where they can track people by insurance claims. And so they followed 273,000 people over 14 years. And what you see is that, again, if you follow the bottom, you can see that's age along the bottom axis. And again, you can see at each time point, as people get older, the incidence, the number of cases that occur of dementia increases with age. So the bottom one takeaway is that no matter who you are, with age, there's an increased incidence. But the other thing you can see here is that if you look at all the different groups, again, you can see at each time point, the African-American group has greater incidence of dementia than every other group. So again, a very important thing that we have to be aware of in terms of trying to take care of people. Other interesting facts, for example, we know that for African Americans, stroke, 44% more likely to die from a stroke, 23% more likely to be obese, 25% more likely to die from heart disease, 72% more likely to be diabetic, and twice as likely to have Alzheimer's disease. And I can tell you that all of these risks, all of these health conditions contribute to dementia. So, when you think about taking care of dementia, there's so many things beyond just your brain that we have to be mindful about. And other things, you have to go see the doctor for your heart. Why? Not just because of your heart, but also to prevent dementia. So this is a really, what you see this data, and this seems kind of demoralizing, but now we're going to look at this data and see that there are things that we can do to change what we see. So this is a really interesting paper, and this is the second version, and I am sure that this research group is going to come out with more, because they've been looking at what affects us over our lifetime and where various risk factors at different points of our life can affect our outcome in terms of developing dementia or preventing it. So at the bottom, you can see there that 40% of potential risk factors are actually modifiable, that we can change that. So early in life, we see that maybe 7% of this risk occurs potentially in early childhood. So education is really important. This is why there's such a big emphasis on sending kids to preschool, because it turns out if you send kids to preschool, that can lower the risk later on for developing cognitive decline and dementia, which is amazing. So such an important thing that we can do for our communities. In midlife, hearing loss, traumatic brain injury, high blood pressure, alcohol in excess, and obesity all can contribute to dementia. And in later life, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. All of this is modifiable. And I am sure that in the next version of this, they're going to put out sleep, because we know that sleep disorders already, there's so many papers about this, that they're going to add sleep, and we don't know what else. So when you think that, there's nothing I can do about this, it's not true. There's actually a lot of things that we're seeing that we could modify our risks. And that's, this is looking at populations, but we can really do something in a greater way. And if we look at how do we even get a diagnosis of cognitive impairment, this is sort of a public health model of health. But when you look at race and ethnicity and how different groups are affected, there are things that happen that are distal from, meaning happen at a very distant but very relevant, impactful way on everybody's life. So where you grow up, what's your socioeconomic status? Have you experienced discrimination? And is there, ways that it's made it hard for people to access what they need to access because of discrimination? And how do you identify? Do you identify as somebody, who would access help? Or maybe you don't even recognize that, you have a medical issue where you need help. Then there's individual mediators, like where are you growing up? What kind of housing do you live in? What psychological stressors are affecting you within you, for yourself, and within your family and within your community? And cognitive engagement, what kind of engagement are you getting from school? Are your teachers engaging you and pushing you forward in life? How are your test taking skills? And then there's things that are very immediate, like what's your physical health? What are your health behaviors? Do you exercise or do you not exercise? Do you smoke? And then you look at access to medical care. And all of these things then combine in terms of how does that, in the end, affect your cognitive function? How does that cause impairment? And how do we then get to a diagnosis of cognitive impairment? So it's not just an individual issue, it's also societal, it's also community, and all these things come together that link race and ethnicity and cognitive impairment. So I'm going to move on now and actually talk about subtypes of dementia. I'm going to be starting with Alzheimer's disease. And a lot of times we'll get the question, I'm worried about my mom and I'm wondering, does she have Alzheimer's or does she have dementia? And that's because dementia from Alzheimer's disease is so common, it's 70% of the cases, that we just kind of think that one is synonymous with the other. But again, it's dementia, and then what does it do too? And Alzheimer's disease is the most common cause of dementia. So it affects more than 6.5 million people in this country. And we know that means that it's about 12% of women and 7.5% of men. It has increased since between 2000 and 2019. Deaths from Alzheimer's increased by 145%, whereas for heart disease, it decreased by 7.3%. And it's very expensive, because it takes so much care. not just the care from doctors and going to the hospital, but also the unpaid care that caregivers provide. It's very expensive. So it's 321 billion in 2022, and that's expected to increase these costs by 2050, could rise to 1 trillion. So this is why we're working on trying to find medications that could treat this disease. And in the meantime, we're working on how can we prevent this from happening in the first place? How can we take care of our health and try to do what we can in the meantime to take care of the people who already have this disease? So what is Alzheimer's disease? So many of you may know this because you're here in a caregiver group, but briefly, we'll just talk about this. So you can see in these two panels on the left-hand side, the left-hand square is picture of one of the proteins of Alzheimer's called amyloid, and it builds up in the brain. We're not exactly sure the reason for amyloid, but we think it's protective at first, but over time it accumulates too much and our brain can't get rid of it. It actually becomes inflammatory, something that's an irritant to our brain. And when we have this amyloid building up, it then causes a protein in the second panel on the right, tau, which is in our neurons, and it's there normally to help our neurons function. It becomes misfolded. And when it becomes misfolded inside our neurons, the neurons actually can't function and they start to die. And when neurons start to die, then they can't talk to each other. And when they can't communicate with each other, that's when you start to see cognitive and behavioral changes that we see in Alzheimer's disease. So we know that amyloid and tau, amyloid across the top and tau tangles along the bottom, start in the memory areas of the brain, and particularly as it progresses throughout the brain. That's how, especially with tau building up, every time the tau goes to a new area, that's how you see new features of whatever's going on with a person, because as the disease progresses in different areas of the brain, those areas, say, that subserve memory or language, become affected. And that's why people start having difficulties. But we know, and this is now, I think, that the Alzheimer's community recognizes that it's not just amyloid and tau. Really, we have all of these things that are contributing, and Alzheimer's and the buildup of amyloid and tau is probably a final common pathway. We know that aging is the #1 risk factor for developing Alzheimer's disease, and genetics has a small part, but there's all these other things that we've already mentioned. So vascular health, smoking, how our diet is, whether we're exercising, what is our environment? Is there pollution? What are our social interactions? If we have less social interactions, that puts us at greater risk for developing Alzheimer's. What's our sleep like? What's our mental health like? And education, a huge part of providing resilience against cognitive decline. There are some really important things going on right now in inflammation. We're looking at cells in our brain that take care of inflammation. And when inflammation goes awry and it becomes overactive, that actually is not a good thing for us. And also some newer topics like gut microbiome and oral health, even how we take care of our teeth. There are dentists that are now looking at the correlation between the bacteria that they see that are in our gums and what's happening in our brain. It's really incredible. So this is a really interesting, broader world than we used to know. And this might actually provide us tools in terms of how can we take care of our health and prevent Alzheimer's disease. So some of the common symptoms, as many of you may know, with Alzheimer's disease is trouble with short-term memory is one of the biggest things that we see first. So repeating conversations, forgetting what day and date it is, misplacing things, forgetting to take our medications, missing appointments, as well as having word-finding difficulties and having difficulty with visual spatial skills, like getting lost, losing our car in the parking lot. And oftentimes the harbinger is a change in behavior. Sometimes this is what we see before we see cognitive changes. So irritability in a person who didn't used to be irritable, depression, anxiety, loss of motivation to do one's activities. And I'm going to now switch into vascular dementia, where we also see a decline in memory and function, again, definition of dementia, but now it's due to vascular lesions in the brain. And you can see two different brains here, one on the left, it says ischemic stroke, and one on the right that says hemorrhagic stroke. So we know that in ischemic stroke, what that really means is ischemia just means lack of oxygen to your brain or lack of oxygen to a particular area. And so that is when you can see on the bottom there, you can see that blood flow is being basically blocked by plaque down there. And 85% of strokes are this type, where you have a blockage. But 15% are actually due to hemorrhagic, meaning it's bleeding. And that means that there's some sort of leak or a rupture to a vessel. But either one of these can cause damage to the brain and cause a stroke and then lead to dementia. So vascular dementia is pretty common. It's accounts for 10 to 30% of dementia cases, depending on what literature you look at. And it's the second or third most common cause of dementia, again, depending on how the study is done. Very common after stroke and very commonly seen with Alzheimer's disease. So a lot of people, maybe 50% of people, also have Alzheimer's. You can have both. Risk factors for vascular dementia are the same things as heart disease and heart attack. So increased risk with older age, but then also with high blood pressure, high cholesterol levels, diabetes. Heart disease itself contributes to this, prior strokes, and smoking. So I don't think that anybody would be surprised by this list. This is a very familiar list, I'm sure. So the symptoms of vascular dementia are a little bit trickier in terms of trying to describe them. And that's because it really depends on what part of the brain is affected to give you the problem you have. So if you have a stroke in the memory area, then you'll have a memory problem. If you get a stroke in the visual spatial part of your brain, you'll have visual spatial problems. And oftentimes a stroke will cause weakness or numbness on the opposite side of the body, one side of the body, because it's also affecting motor pathways or sensory pathways of the brain. So a stroke can happen, and all of a sudden, if you have a big stroke, then if you were functioning like this, you may have what we call stepwise decline. The stroke happens and then you have a decline. And so you'll have dementia where you're having rapid drops and it happens all of a sudden. But sometimes you can have high blood pressure, diabetes, and cholesterol in very small vessels that can slowly affect the very tiny vessels in your brain. And so you could have actually cognitive decline that looks very much like Alzheimer's disease that happens very slowly over time. So if you have a memory concern, you should tell your doctor. And even if it's a little thing, you should still go. It's really important to get an evaluation for cognitive impairment because there may be nothing very serious going on, or it could be something that's treatable. What if you have obstructive sleep apnea? We can do something about that. And if we catch it, not only will we help your brain, but we're going to help your heart and lungs because sleep apnea is really bad for heart and lungs. It can cause heart failure. So we want to know if there's something wrong and be able to impact that if we can. And if it turns out, for example, that there is something like Alzheimer's disease going on or something like vascular disease going on, we want to provide appropriate treatments. It's important that we do that and do that as early as we can. It also is an opportunity to participate in a clinical trial. I can tell you that there are so many studies going on right now where we need people to participate because we don't know what's going to work. And as a friend of ours says, the first person to be treated from Alzheimer's disease will be somebody in a clinical trial. And that's really true. So, and different people are affected different ways. We know for high blood pressure that depending on what your ethnicity is.
You want me to pause it for you?
Yes. We know that if you're African-American, we're going to start you on one type of medication. And if you are Caucasian, non-Latino, we're going to start you on something else. And we only know that because people participated in trials and we were able to figure out that different medications are better for different people. The last thing is it's important for you to be able to make a plan for care in the future. We want people to be able to speak for themselves and be able to plan with their families and friends what they would like if it turns out that this disease is going to get worse. We don't want things to happen all of a sudden. It's really hard to make decisions and make care plans under duress. We want to have a good plan and we want to know what it's going to be so that it's smooth. Who can help you with this? Your internist or a geriatrician who's an internal medicine doctor who specializes with working with older people, a neurologist like myself, I'm a brain doctor, or a psychiatrist or a geriatric psychiatrist. Again, they are very capable of helping make a diagnosis and help figure out why you might have a memory problem. So again, how do we diagnose this? First, you have to go to a doctor or a nurse practitioner or a PA, and we will interview you, kind of get some information about the problem that you're experiencing and do a physical exam. We'll do a cognitive test to test your memory and thinking. And then order some blood tests. Sometimes people have vitamin deficiencies, or maybe their thyroid isn't acting right. And we want to check those things. Again, we're trying to check for what we could fix. We also will do a brain scan, preferably a brain MRI, but sometimes if you have a pacemaker, we can't do a brain MRI. So we'll do a head CT. And sometimes we'll do another scan in addition called a PET scan, which I'll show you a little bit later. But what we're looking for is, are there strokes that we can see that you've had before? Is there part of the brain that is smaller than it should be? That might be the reason why you're having difficulties. And we might also order, say, a neck or brain vessel scan. We might do carotid ultrasound, something to look at the neck vessels and your head vessels. Because again, if you're at risk for vascular disease, if we need to go in there, say, to do an operation because there's a real big, real tight vessel, we'd like to be able to open it up and prevent a stroke if we can, or at least put you on medications medically to do medical treatment. There's also heart studies we might be doing to make sure that your heart is functioning okay. And if we need to, and we're not sure, we might do cognitive testing with a neuropsychologist who can better assess how you're doing. So I just wanted to show you a little bit at what brain scans look like. These are MRI pictures. And on the left-hand side, you can see somebody who has normal aging. Their brain is very plump, and you can see the red arrow pointing to the hippocampus, which is the area of our brain that helps us record new memories. That's your tape recorder of the brain. And that's what helps us, learn new memories. And then the memories go from there and get distributed all throughout the brain. In the middle is somebody who has mild cognitive impairment. That means they have a memory problem, but they're still functioning okay. They don't have dementia. It's mild cognitive impairment. And you see that area again is a little bit smaller. So it's shrinking. It's maybe not able to function as well as it used to. And on the right-hand side is somebody who has dementia from Alzheimer's disease. And you can see that their whole brain has a lot shrinkage, and particularly the hippocampus as well. This is an MRI with examples of people who might have vascular dementia. And as you can see, it's really varied. So say the upper left panel to panel A with all the arrows, it's showing white matter disease. So this is changes to the white matter. The white matter is what connects various areas of the brain together. It's like telephone wires that help connect things together. And if you have a lot of damage to that area, you can see how your brain wouldn't be able to function very well. In panel B, just to the right, if you can see where that arrow is, it's pointing to a whole area of brain that if you look to the comparative side on the other side, you can see that it doesn't look very healthy compared to the other side. And that's because that person had a very big stroke. So this is the kind of stroke where they were doing fine and had a very big lesion and probably had a very big decline suddenly in their cognition. The one other thing I'll show you is panel D. You can see that there are two arrows, and it's particularly the one that's pointing in the middle, the left-hand arrow. It's a tiny little black circle that it's pointing to, a tiny stroke, but it's in a strategic area that would affect somebody's memory. So it's amazing that one tiny little thing could do so much. So this is why vascular dementia is really tricky. And you can see it's very hard for us to sort of categorize what would you expect to see from it, because it really depends where the lesion is. Lastly, I'm just going to show you what a PET scan looks like. A PET scan is where we give you give you an IV, and it goes and gives you glucose, and your brain and your whole body uses glucose. And then we look at the pattern of how your brain takes up that glucose, and then we can see what parts of the brain might be working well or not. So if you look at the bottom row, this is somebody with normal cognition, and you see a lot of good activity. And we can tell that because it's red. That's how the color coding is. So the color code for red, you have more activity. So that's a healthy brain. If you go one row above, again, that's somebody with mild cognitive impairment where they have memory difficulty, but they're still functioning okay, but they're definitely having memory problems. And you can see already there's less red. It's more orange, maybe yellow. And at the top is somebody with dementia due to Alzheimer's disease. And you can see that a lot of their brain is not red now. It's maybe yellow, very light yellow. And especially in the hippocampus area, I don't know if you guys can see my my cursor here, but this hippocampal area, a lot lighter. So you can see that this person's having a harder time in function-wise. So lastly, how do we treat dementia due to Alzheimer's disease or vascular disease? Well, first, we need to treat all the risk factors, right? So if you are somebody who's at risk for vascular dementia, and you have high blood pressure, or you have diabetes, or you We want you to change your diet. We want you to stop smoking. We want you to take medications as directed to try to keep your blood pressure down and keep your diabetes in check. Also really important to exercise 30 minutes a day, eat a healthy diet. If you can't hear, get hearing aids. It's actually a risk factor. Hearing loss is a risk factor for dementia. So if you can't hear, get your hearing aids, and to drink alcohol in moderation. We can also use medications. Obviously, we do have medications for treating, we're trying to treat the symptoms of Alzheimer's disease. And we use some of those same medications actually for vascular dementia as well. But just as important, again, I have exercise at the top because if there's one thing you can do, it's exercise. You can slow down neurodegeneration just by exercising 30 minutes a day. It's in your hands. Stay engaged with friends and family. We have data to show that people who have more social connections do better later in life with their memory. Challenge yourself in fun brain activities. And it doesn't have to be the crossword puzzle if you hate that. If you like reading books, if you like going to museums, if you like doing card games, anything that you like, you'll have a better success at doing it because you like it, and you should stay engaged. Keep a regular sleep pattern. Sleep is so important. Sleep is the one time where we clear amyloid out of our brains. It's your one shot during 24 hours to have that happen and to give your brain and your spirit some rest. And lastly, take care of mental health. I know it's a stigma, to talk about depression, to talk about bipolar disorder, to talk about anxiety, but these things are real and we are human. And we know that these conditions cause inflammation in our brain. So we need to be able to take care of our mental health, reduce our stress, which again, then reduces our risk for developing dementia. And with that, thank you very much for allowing me to speak with you all today, and I'll be back a little bit later to answer questions. And I will now attempt to stop sharing. All right, thanks.
Thank you. So, Monica, or anyone, are we opening up for questions now?
Yeah, let's definitely. I think it'd be a good thing to open up for some questions with Dr. Kremen, and then we can then go into Tonya with our self-care piece.
Thank you. I was just going to suggest that. And if Dr. Kremen can speak to, as you were sharing about smoking, many people sometimes don't smoke, but what about secondhand smoke? Because that seems to be just as powerful as it relates to the effects on the body.
Right. Yeah. I mean, secondhand smoke, we know is not good for our lungs. And we know that, again, they've just put on that, that swoopy diagram I just showed you that air pollution is a factor. So I think that there is a recognition that the quality of our air is really important. And so secondhand smoke is probably, can cause risk. Again, it's probably inflammatory. And there's a lot of research right now being looked at inflammation in the brain as too much. So too much inflammation can be bad for your brain and cause, contribute to neurodegeneration. So yes, I think that secondhand smoke is probably a risk factor, just like direct smoking is.
Thank you.
Is there any reason why the percentage of African Americans has a higher percentage? Is there any known factors why that is?
So it's very multifactorial. And I think that a lot of the discussion actually that's come out through COVID, right, about structural racism and access to care. I think also what we call about unconscious bias, right? How that, that happens for women versus men, and it also happens across different races as well, that there are assumptions that, one person comes in, they have the same complaint, and depending on what they look like it or not, people will make assumptions. There's a lot of things like that that are causing it. And also, what community are you growing up with? What access to healthcare do you have? Is it easy to get to that place? And in addition, how is it easy for you to get to the right food source, right? If you have food deserts and the only thing that you can access that's cheap is, junk food, really, all these things pile up, and it's probably also generational. In addition to all the things that we have to deal with anyway, that all of us are dealing with, which is genetics and high blood pressure, diabetes. So there's a lot of work being going on right now in the public health field, looking at why is this happening and what can we do to change that? And it really does have to happen not only at an individual level, but at a structural level, right? We have to make sure that there's enough healthcare providers to go around and in the right neighborhoods where they're going to be treated the right way, where the concern is going to be heard appropriately, and the right thing happens for everybody. So it really does matter. It really, really does matter. And I think that's partly what contributes to this difference.
There's also the issue of the complexity. I'm part of a coalition that started out just as a health clinic in a Black community back in Jersey, and it's now expanded to a nationwide sort of initiative, I guess you call it, because they said they realize we're complex people, regardless of race, creed, or color. And so much was looked at just for one isolated piece of what's going on. And one of the things that they added 3 years ago or 4 years ago was looking at even caregivers. And so now we're an important part of that. And they said people coming out of prison have a whole different set of issues, even though the health issue is the same, but what it takes to get there. And the people experiencing homelessness. So they've added all of this to the movement. And in fact, this year, California is blessing that their conference is going to be here. And they're trying, so if anybody on here or knows of any organization or health group that would like to participate, if you could either let Sharon or Petra know how to, because I'm going to sending both of them the information. They want people to become part of it. And dementia and all, I mean, because that's why we've talked to Petra about it and others. They've got it, like I said, they realize they've got to start looking at the whole picture. And of course, we talk about racism, but racism doesn't even matter if they're not looking at you as that whole person.
Yes, agreed. And that's what makes, when you read these papers, right, it's like, there's so many factors that you have to look across. I mean, you're exactly right. It's not just one thing, it's many things. And also the interaction between all these different things, right? So it's very, very complex. You're absolutely right.
It's right to a point, but years ago at Daniel Freeman Hospital, my father was in the ER. My mom and I arrived and they told us, don't worry, he's just drunk. So my mother asked my father 3 questions. What's the year? He got that wrong. Who's the president? He said Truman. And what's one and one? And he answered something. And my dad's an engineer. So my mother, that's one of the few times I embraced her fiery personality. She asked the staff, the nurse, has this man been examined? And they all said no. He was smiling, ergo he was a drunk. When they examined him, he'd had a hemorrhagic stroke. And he'd been sitting there in the ER bleeding. The more you bleed, the more brain you lose. And this was a 47-year-old man. So by the time the neurosurgeons arrived and the operation took place, he lost 6, 7, 8 hours simply because they saw him smiling black drunk. No need to even examine, not even a cursory examination. He was grinning, they laughed and said he's drunk. We were just waiting for somebody to pick him up. So it's from the time you walk in the door when the assessment of your care is being made. And that's the part that's got to change.
Doctor, can you speak a little bit more specifically on your thoughts concerning plant-based diets and the benefits that can be derived from that, specifically with respect to underlying illnesses that you've mentioned can give rise to Alzheimer's dementia, as well as its direct impact on Alzheimer's dementia? type illnesses?
Well, I think the thing that we know is that obviously, from meat-based diets and particularly red meat, obviously there's cholesterol, which is one of the things, and trans fats that we are trying to avoid, right? And obviously you don't have that with plants. And so obviously you're not going to be introducing some of those inflammatory factors into your brain. And there's a lot of antioxidants and other types of nutrients that you can derive, that can be derived from a plant-based diet. It has to be done carefully though, because you have to make sure that you're still getting all of the protein and nutrients that you need. I am not, particularly an expert or a proponent of any one particular diet per se, as long as you're getting everything that you need and you eat everything in moderation. Of course, making sure that you're not eating a lot of sugar and that you're not eating a lot of the trans fats, which again, we know contributes to cholesterol, higher cholesterol. I mean, we all need some cholesterol. I mean, cholesterol in and of itself is not necessarily bad. We do need cholesterol because it helps shuttle other important things around your body. So if you don't have a lot of cholesterol, that's also not good, right? So whether there's been any specific work looking at, a plant-based diet, specifically how it contributes to reducing risk for Alzheimer's disease, that I'm not aware of per se, but clearly you can see that it would be less inflammatory, less pro-inflammatory. It would be more anti-inflammatory, and that's probably very helpful.
I had a question. What's the current standard of care for the diagnosis of the various types of dementia, and has that changed over time? And the reason why I ask, my mom was a Kaiser patient in the past. Now she's at UCLA, but she was diagnosed in 95 when she was 95, and now she's almost 102. But all she had was kind of the cognitive questionnaire, right?
Right.
There was no imaging offered, nothing else. And she does have hypertension, now profound hearing loss, mild hearing loss. She's on her third generation of hearing aids now. But I sort of looking back, realized that she did not get worked up at all. And was that pretty typical about 7 years ago, or was that not the standard of care?
Right. I will tell you this, what I am giving to you is what I would say that the Alzheimer's disease centers at the highest level, this is what we expect. And this is the standard that we expect. Whether that gets carried out and trickles down into community hospitals and community practice, it takes a longer time. And I will say that what happened with your mom is fairly typical a lot of times in private practice or in the general community. That, again, what I'm telling you is that it's not inevitable that everybody's got to get dementia, and it's not inevitable that having memory problems is a normal part of aging, but even that we didn't always know that or think that. And there's still a generation where, well, they have dementia. What are you going to do about it? So I would say that was typical, but what I would say is demand more, because we do need to know more about what's going on. There should be a brain scan done. Now, I will say this with the caveat that if I have somebody who comes in and they're 95 and something's been going on for a very long time, and now they're coming and say something's been going on for 5 years, and it's very clear to me that somebody has dementia, I might double check before I decide that I want to shove a 95-year-old person into an MRI scanner, right? Because is it going to get me more information that's going to be useful at this point? If I already know that they have high blood pressure and they've had a stroke before, or they've had a heart attack, probably not. I think then I would be making sure that their blood pressure is okay. I would make sure their cholesterol is okay. I'd be making sure that they can get as much exercise as a 95-year-old person can do. And I would try, it does depend. I mean, I'm not to say, and I don't want to be ageist and say we're not going to treat people who are 95. We do, but it depends how they're doing. Like if they're a 95-year-old person who just is now having problems, yeah, we're going to work that up and just see what's going on. Because as somebody just mentioned, if there's a stroke or something we need to do something about, let's do something about it. If they're living a healthy, productive life, we need to do something about that. But I will say, yes, go ahead.
I was going to say, Dr. Kremen, if we can, I want to get to Imelda and then
Yes.
Karen. And then this is always great. And I know we
Yeah.
can like talk to Dr. Kremen all day long, but I also know that we really want to get to the part with
Yeah.
Tonya and talk about our self-care piece.
Yeah.
So let's go Imelda and then Karen, because you officially have your hands up, or at least Zoom wise. And then we'll just do these two last questions. And if anyone has additional questions, please put these in the chat. And Dr. Kremen could answer some of these questions for you that you may have while Tonya is doing her piece, or we could just follow up with you afterwards. Go ahead, Imelda.
Yes, thank you for recognizing me. And I kind of like to piggyback on Vanessa's statement. I just really want to understand how to be a better advocate and caretaker for my husband. I am concerned that we have not gotten all of the diagnostic information. My husband has been diagnosed with mild cognitive impairment, that there's evidence that it's progressing, but he still is high functioning. But I don't know how they got there. He didn't have like a neurologist. He didn't have any kind of extensive, evaluation so that we can know if there's something we can be doing. He's healthy, he's 79, he exercises, but he has had a number of things like he has sleep apnea, and they do things like, oh, he's got kidney stones, so let's remove that, and I think something else like a hyperparathyroid. So I kind of feel like he's like a little pin cushion right now, and we're just dancing around the core issue. And I want to understand what's the best avenue for me to like embark on to really be a better advocate for my husband, so he can live his best life. I can live my best life as he's going through all this. Can I demand certain?
Yes. So this is what you do, I think you tell his primary care doctor, look, this is our concern. And you push and you say, this is our concern. We notice that there are these changes. It's okay. You can do that. That's your role. And say, look, I want to know, we need to know, why does he have cognitive impairment? We would like a thorough workup. We would like a referral to a neurologist. If your primary care doctor doesn't feel comfortable doing it, ask for a referral.
Perfect. Thank you.
You're welcome.
Thank you, Dr. Kremen. Karen, you want to unmute and ask your question?
Sure. Thank you. Thank you so much. Really so interesting. I love talking about the brain. So much to learn. But I have a question. My husband has been diagnosed with Lewy body dementia. His mother had vascular dementia. She passed away from that. He's 72 and he's a neurologist. They've done the PET scan with contrast. He said he's got the markers for it. He recently had a hospital stay on May 19th where everything on the left side was affected. And so we went thinking he was having a stroke. He also has coronary artery disease. And his left leg was totally immobile. It was like 100 pounds. And so they didn't send him home. They put him into rehab. They said it was a stroke, and they did MRI, no stroke. And prior to going in, he had real bad tremor on the right-hand side. So we went back to see the neurologist, follow up. Neurologist talked with him and thinks that he had, said it's very closely related to seizure disorder. And he was on seizure disorder medication before he was diagnosed with Lewy body. And he said seizure disorder and that strokes are very closely and difficult to figure out. Now my husband has no tremors and he's walking, first with a walker. And I mean, it's like a miracle, but it's so quickly. And they sent a lift for him, a hospital bed. Thank God we don't need all that stuff, but it's very puzzling to me.
Yeah. So maybe we can talk about this offline, because that is very detailed, very complex.
I'm sorry.
No, that's okay.
I'm a good advocate for my husband. Oh my goodness. Yeah, it's been a bit of a roller coaster.
Yes, it sounds like it has been.
And I think that's also like sort of like good example too of how unique all this is, like for each person. You know, it's one of those hard things, as we say. I know I facilitate a few support groups, and I know Sharon and Jeannie probably have this a lot, where people come up and they say, well, I tried blank that everyone says works, right? Everyone says, oh, if you do this, this is going to help. And it didn't work for me. And because we see how unique this world of dementia is for everybody, and how everyone's journey is just so different. So I definitely think, Karen, maybe you and Dr. Kremen can, I can connect the two of you and we can try to give you some additional help and support on that.
Okay.
I know we
Thank you.
are, it always seems to be the way, I think, at least in my world, that like meetings end up running out of time, right? Does everyone always run out of time? Is anyone actually on time around these things? So I want to be able to pass this over to Tonya Jones. Kimberly, how long does Tonya have? Give us her time frame.
So so our meeting normally goes till 1. And so how much time does she need?
Well, she could probably do an hour and a half herself, but we're not talking that.
But she has, she can start, if she starts now, she should be finished by 12:45 still.
Oh, absolutely.
Because it ends at 1, so that's.
But could we push that to like maybe like 12:50? We got a little extra time there.
12:50 is fine. 12:50.
Perfect, great. All right, Tonya, it's yours. I'm passing this over to you.
Thank you. Thanks so much. Yeah, so we're gonna do a condensed version, so you all bear with me. And there might be times I might even talk a little faster than I usually do because, you know, I'm I still want to be able to just touch on a few things. So thank you for having me. This is my third time visiting this group in some form. And I just have to say, every time that I have come, I just feel really open-hearted, very tender, and it's really like just a testament to the community that you've created, and it's so palpable, even through Zoom, that it feels just so loving and supportive and kind, and so it's really just a pleasure for me to be here. So I wanted to start with just sharing a quick quote that some of you may have heard, or some form of that quote, from Audre Lorde, who's a Black feminist and civil rights leader, or was deceased now, that self-care is not self-indulgence, it is self-preservation. And, you know, when I think about that, just that alone, this idea, and especially like within historically in the Black community, like how we think sometimes about self-care and this tendency to prioritize the needs of others, and just assuming this is for the greater good for ourselves or for other people. And I think there's also like some racial, historical, social context to that as well. I'm going to make some assumptions here, but I'm assuming that maybe even growing up, there's some of us that have heard like, oh, you have to be, twice or 3 times as good as someone else, or work so hard that they can't deny you. Again, we talked about how many Black women are, or women just in general, are caregivers, just the ratio. And when you think about like Black women, then you also have this trope of the strong Black woman. And, this goes back even further, I think, when we think historically around being at the forefront of just political and social movements that, could have made rest and self-care just feel like it wasn't an option. And this dates all the way back even to slavery, where, people were sold from their owners or separated from their families because they were seen as not working hard enough, physically harmed, some even killed. So, when we take like all of that kind of historical and context, the view of self-care can seem indulgent or like a luxury that we can't afford, or something that can actually literally be dangerous to indulge in. So, I think it's really, whether that's like conscious or unconscious, not even, below the surface, like, just one kind of looking into like how that conditioning may be present, in our communities. And for me, I truly, truly, in my heart, believe it is so important for us to reclaim our right for greater self-care, our need for it, our need for rest, and just realizing like how vital it is really to our very survival and our well-being, and that we are worthy of taking care of ourselves. And if we kind of take that out of that context, even in a broader like American culture, it's just so deeply ingrained in our culture, to always be working and doing. We could never do enough. Productivity and success at the expense of our mental health, our physical health, our emotional health is somehow noble. I've even, heard people say to me, I'm 46 this year, and sometimes I'll say I'm tired, and they're like, "Girl, you too young to be tired." I'm like, "No, it's been a long day. I'm tired." Or this one. This is the one I hear. I want to go to sleep. Oh well, you can sleep when you're dead. I'm like, well, that's probably going to happen sooner rather than later if I don't sleep. So all these kind of just things that we're hearing that's like a part of our culture does not support self-care. And as Monica mentioned earlier, that we can't really be there for others if we don't take care of our own well-being, and we can't really be there for ourselves. So I think I just started talking about this before we even talk about mindfulness in other ways, because I think it's important to kind of, I guess, evaluate, like to look at even our thinking around self-care, because that can impact how we prioritize self-care and the steps that we take. If we first just look at like how do we relate to self-care more generally speaking. And I think if that mindset is there, that we are worthy and this is important, then that could be a shift around how we can fit self-care into our lives. Because doesn't have to be a perfect time or a perfect place. I need this many minutes. It's like whatever you have is perfect because that's what you have. If it's 5 minutes, then that's the perfect amount of time. If you're sitting out in the car and it's like in between an appointment, that's the perfect place because that's what we have. That's what we're working with. So nothing could be more perfect than what's there, right? You can't make it something else, So with that, there are many like ways and tools that we can use to practice self-care. And one of the practices that's been really beneficial for me is the practice of mindfulness. And it's such like a broad term. It's like, how do you define mindfulness? And I think sometimes the challenge is that is because it's something that is experiential, rather. And that experience can look different for different people. And back to kind of cultural conditioning, the piece around I have to explain it, I have to intellectualize something versus like lived and felt experience. And so much of the practice of mindfulness for me, whether that's just being in the world or formal practice, meditation practices, which we're going to do a little bit of in this period, really is sometimes something that is hard to really capture with language. There are limitations to language. So just a simple kind of definition of mindfulness is paying attention to our present moment experience with openness and with curiosity and a willingness to fully experience what's happening, what is, whether that's externally, what's happening in our minds, in our bodies, in our hearts. Not pushing away, we're not judging, we're not like, I gotta hold on to this thing or not. It's just like, can I just be fully present with what is happening? And recently, so I go on silent meditation retreats pretty often, and I was on a retreat a few months ago, and we were outside doing walking meditation. And it's kind of like, the mind could wander, and it's like, oh, this thing would be more exciting if only I had this, if I had that. Then I have these random thoughts where I compare myself to the most successful people in the world and go, why, if they did this, why can't I, kind of thing. And then there was just a moment of really stillness and quiet, and the thought came to me, what is more interesting in this moment right now? Like, this is my life. Like, what out there, whatever, like, what could be more interesting, more important, more impactful in this very moment of my life? And that could sound a bit simplistic, but for me, it was just like this kind of profound thing that felt so embodied. Um, and it was probably for the first time that it fully felt that way, that it wasn't something I was trying to practice or think of. And oftentimes, in those moments that may not seem on the surface to be like the most extraordinary moments in our lives can be the most meaningful and impactful and profound. And that's, what I've been finding. And when I reflect on time, it's just, I've been finding like, yeah, like those things that seem like, oh, I'm just doing that thing. When I brought my full awareness to it, my full heart to it, it wasn't just doing a thing, And so, with mindfulness, and I guess that there are some things I'm going to kind of go through here, but that's like a more kind of, I guess, standard definition. But to me, what really comes to mind is honoring yourself, honoring all of your experiences, all aspects of your life, loved ones, and really just the full range of your humanity. Your inner life matters. So I know we have maybe about 15 minutes, so I kind of want to just skip through a few things and just take some time to be able to do a practice together. And the practice we're going to do is a body scan and breath meditation. And it was really, it feels timely and appropriate, so yay. Like I feel like my little spidey senses were there. Because, when Monica was speaking earlier and asking people about processing stress, a lot of people talk about the body, and when I said, even for myself, checking out, it wasn't about like not doing the task or not like kind of doing the things I'm supposed to do. It was more about like checking out it from my body and kind of like, I'm not gonna think, I'm not gonna feel. So cutting off that thing that makes me human, just to get through. So in practicing mindfulness, there is like that, how can I still do the things, whatever I'm doing, even if things need to be done, things I want to do, and still be present and not check out, like that numbing kind of thing. And that was the kind of context of what I was speaking of around like checking out. So most of you are seated, but I invite you first to just get in a position that feels comfortable for you. If you're seated, or even if you want to lie down, this is a more informal, formal kind of practice, so to speak. So sometimes you're doing breath meditations, you'll want to be upright, but with a body scan kind of meditation, you really want to get into a comfortable position that feels good for you. If you need any pillows or any shifting, I just want to set my timer here. So I invite you to close your eyes if that feels comfortable for you. Or if not, just lowering the gaze. And kind of just letting the eyes rest so that there's not a strong focus. And you can also turn off your camera if that feels more comfortable for you. And as you can see, I'm gazing downward when I'm on camera. That's usually what I go with, rather than closing my eyes. So I invite you to take a few deep breaths at your own pace. And just seeing if you can connect with the sensation of the breath, the inhale and the exhale as it travels through the body. touching the sensation, not thinking about the breath, but feeling it. And allowing your breath to transition to a normal pace of breathing, whatever that is for you. That may be short or long, deep or shallow. Just connecting with the natural rhythm of your breath. And feeling the weight of your body on a chair, a bed, the floor, if you're lying down. And on the exhale, just seeing if you could let go a little bit that you might be holding, whether in the mind, the body. Have a sense of relaxing just a little more deeply. Not forcing anything. And you're starting up at the forehead, bringing your attention to that area. Noticing if you're feeling any tightness or tension there, the scrunching. And if so, not judging, but allowing the exhale of the breath to support you, and seeing if you can soften and release a little bit there. Moving into the jaw, noticing any tension or tightness. Seeing if you can let the jaw loosen and hang a bit. And we're still breathing, still staying connected to our bodies, our breath. And I invite you to see what's present in the neck or shoulders. The weight, the sensations, warmth, coldness, tingling, the tightness. Many people mentioned, it's also true for me. I often hold tension in my shoulders. So if you notice that, seeing if you can let them drop and fall a bit. Even if it's just 1-2% more. Practicing with ease and what's available to us at the moment. And checking in with the arms, hands, letting them fall and rest wherever is comfortable for you. And as you bring more attention to these places in the body in this way, you may notice sensations that you may not notice just kind of going through the day. Or you may not. So even noticing that too, there is a quality to that feeling in the body as well. Perhaps noticing rise and fall of the breath in the belly, if that feels comfortable for you. Sometimes the belly can hold a lot of emotions too, so if something arises that feels strong there, it's okay to back off. Maybe bring the attention to the hands if that's more comfortable. Bringing attention to the thighs. Allowing them to be soft. Just really seeing what you can let go of right now. There are thoughts arising. Whether the past or present projections, things to do. Just seeing if you can allow yourself these moments just to be present and enough, just as you are right now. Continuing down the body, your knees and shin. Softening. The top of the feet. The bottoms of the feet connecting to the ground. Relaxing into that support. And noticing and taking in your whole body. Feeling the breath move through the body. Connecting with the felt sense of what it feels like in the body to be here, alive and present at this time. Taking refuge in this moment of awareness, of being. As we come to a close in this meditation, I invite you to take a moment to extend some gratitude to yourself all your goodness, all the ways that you show up for yourself, for others. And perhaps even silently reflecting, repeating a few phrases for yourself. May I be happy. May I be well. May I be at ease. Or any other phrases that feel natural or supportive. And in a few seconds, you're going to hear the sound of the bell.
And if your eyes were closed, you're off screen, being gentle, and opening your eyes and returning back to our Zoom space. And I'm seeing here, so even though we just took maybe about 12, 13 minutes or so of doing a body scan, like, if you only have like a few minutes and you're kind of going through your day or doing things and you feel something, arising or that would feel supportive for you, you don't need that much time. You can do a pretty quick scan of the body and connecting with the breath in just a few minutes. One of the things that I've done too sometimes when I'm going through my day, and I call it 2 feet, 3 breaths, where I'll simply just, stop where I am and connect to the sensations like at the bottom of my feet. And then I'll stop and take just 3 breaths and I'll ask myself, what do I need right now? Or what would feel most supportive to me? What could I do in this moment to care for myself? And sometimes it's just taking those breaths. Sometimes I need to, I could just look at a tree, have a cup of tea. So, and there are other ways that, we can support ourselves with self-care, but I want to be respectful of the time. But, I just wanted to kind of leave you with that, it doesn't have to be like I've carved out these 20, 30 minutes every day. And if I can't do that, then I can't do anything. Again, whatever time you have is the perfect time, and work with that, with the things that could bring you some ease and some peace, some calm, and hopefully some moments of joy as well. But thank you for having me again today.
Thank you.
Thank you, Tonya. Teacher, I believe you wanted to say one more thing.
This is so exciting, and thank you, Dr. Kremen, Monica, Tonya. This discussion about self-care and the emphasis on self-care is an ongoing one. And as long as there's a need for a support group, there will be a need for self-care. So this is not the end, and thank you all for joining us today.